Thanks, yeah.
Oh,
Just remember to speak up a bit so that they can hear.
sorry. Can have the. That's the one. Okay, so my presentation not just utilize that. Oh no. Sorry. Okay. Oops. But so my presentation or case is about patient SN, who is a 60-year-old lady, is it loud enough? 60-year-old lady from Friedenberg. So she's previously well and reported to not wear contact lenses. So she was referred from a private ophthalmologist to Westhuyzen for the management of a left corneal ulcer. She sustained vegetative trauma to her eye 6 weeks prior to being seen by the private ophthalmologist, and she reported to that she ran after a chicken and into a haystack. Then she received initial treatment at the GP, and she was prescribed topical corticosteroids, but there was no improvement in her condition. And then she sought help from the private ophthalmologist, and then she was seen at Westhuyzen end of April with most likely infective keratitis, and they thought it's either bacterial or herpetic of origin. Okay. So on examination, the patient examined all other systems examined normal. Her right eye was normal visual acuity. Her left eye, however, she had decreased visual acuity and could only see hand motion. Her lids were edematous, her conjunctiva, there was injection present in her conjunctiva. She had a corneal epithelial defect, as you can see in the pictures. That's just example now, obviously don't have pictures of the patient. She also had decreased sensation. They visualized the hypopion. There was no issues with her pupils, and then they were not able to visualize the vitreous fluids due to the epithelial defect. So the plan from the ophthalmologist at that stage was to get a corneal scrape for MCNS, for bacterial and fungal MCNS, and then they also prescribed her oral acyclovir, oral doxycycline, and topical eye drops, which was ofloxacin and temozolone, covering herpetic and bacterial keratitis, but they noted to have a low threshold for fungal keratitis if she doesn't improve on this management. So we received the sample the following day. We didn't receive stains, but just inoculated media for bacteria as well as for mycology. So after 2 days, we reported no bacterial growth, and around this time, they noted that there was no improvement on the current management, and the cornea was more hazy. They thought they saw a ring infiltrate, and the plan was then to treat her rather as a fungal keratitis. And at this stage, the mycology or the fungal cultures were still pending. So they added natamycin and amphotericin B eye drops, and also prescribed an oral voriconazole. 6 days later, still no real improvement noted. They scheduled her for a glycerol graft, and then also decided to continue the antifungal treatment for that time period. And so in mid-May, we received this corneal tissue that they got from this procedure, and it was against a bacterial, fungal, and fungal MCNS, as well as histology. So the next day, our colleagues at the NatPac reported that they saw double-walled cystic structures highlighted by the PAS and the Grobot stain, and that was highly suspicious for Acanthoemba keratitis. So when the ophthalmologist saw this report, they obviously phoned us and wanted to know how far the Acanthoemba culture is, which I had to inform them that we don't perform this at our laboratory. It's not part of our routine diagnostic methods. And then we arranged with with the NICD, the Emerging Zoonotic and Parasitic Diseases Center, to send off the saline that the sample came in, as well as the VHI graph that it was put in, send that to the NICD, which did a PCR for us, as well as the Acanthoemba culture, and it took about between 2 and 5 days for the PCR and the culture both to come out as positive. So obviously my talk is about Acanthoemba keratitis. But before we get there, Acanthoemba species are part of the free-living amoeba. So they are protozoans that are present in the environment, and they're only opportunistic parasitic. So they don't need a host to live. They can live on their own in the environment, hence their name. So they found globally in a lot of, or most water and soil sources. There's 4 main genera that cause disease in humans. So Nigeria, and there's only 1 species in that genre, Nigeria fowleri. Acanthoemba, there's several species. Then we also have Palamuthia, and the species causing disease in humans is Palamuthia mandibularis, and then also some peanut species, but there's only been 1 case of human infection with this species. So all of them have 2 stages, a cystic and a trophozoite stage, and Nigeria fowleri also have this additional flagellate stage. The trophozoites are the infective stage. They feed actively, divide by binary fission, and then the cystic stage occurs when the environment is not favorable and the trophozoite insists. And they have little pores or osteols where they sample from the environment continuously to see if the environment is favorable for cyst, to become trophozoites again. So I'm not going to go into this whole table, but this is just comparing the clinical manifestations of the for the 3 most common genre. So Nigeria fowleri causes PAM, or primary amoebic meningoencephalitis, which occurs, or anybody that has exposure to fresh water can get this disease. It's usually very prominent, a rapid onset from symptoms to death. And usually you can detect or visualize these organisms from the CSF itself. There's a whole range of diagnostic methods that you can use, and on imaging you will see a leptomeningeal enhancement, necrosis, or hemorrhage of the brain. And then also there's not a lot of survivors of this disease, so the treatment is sort of experimental, it's not confirmed. Then Acanthoemba and Palamuthia both causes GAE, or granulomatous amoebic encephalitis, which is more of a subacute chronic disease, and that can on imaging cause a ring enhancing lesion. And for samples for this type of disease is brain biopsies, and that's where you will detect the trophozoites from. Just to note that Nigeria fowleri and Acanthoemba can be grown in the lab with bacterialized media, whereas Palamuthia can't. And then there's also multiple agents that have been used in the management of this disease. Oh, and Acanthoemba and Palamuthia is also more seen in immunocompromised patients. So back to Acanthoemba keratitis. So it's a very rare eye disease. It accounts for 2% of the global corneal infections. It was first described in the UK school teacher by Narginton in 1974, but since then there's been found worldwide. A review article from this year calculated the global incidence of this Acanthoemba keratitis to 2.9 cases per million people, but obviously this is not a notifiable disease, or it's also not well reported in countries, so this is just a rough estimation on case reports and case series published by the different countries. The highest incidence seems to be from India, and the lowest from Tunisia and Belgium. And as you can see, there's a lot of countries that there's no data from. So since contact lenses became popular in the 1980s, there's been an increase in these cases, and also outbreaks tend to be confined to specific regions. So in South Africa, there's not a lot of clinical cases reported. Here's a case from 2000. I think Korean was involved in this, where it's a dual infection, where they describe a patient with dual infection of Acanthoemba and Pseudomonas species. And then also the NICD bulletin had an article on archival samples that they determined the genotype of its Acanthoemba species, which they found to be genotype T4, which is worldwide also the predominant genotype that causes Acanthoemba keratitis. The rest of the literature is basically environmental samples that was tested for Acanthoemba, ranging from hospital water sources to public or household water sources. So not a lot of cases that have been reported. So for risk factors, obviously water is the main source of Acanthoemba. So that ranges from fresh to salt to bottled. So hot tubs, swimming pools, basically all water sources have Acanthoemba species. Then contact lenses is a main risk in developed countries, and it's linked to 86% of Acanthoemba cases, and that is usually due to inappropriate cleaning of your lenses using tap water or homemade solutions, also poor hand hygiene when you deal with your contact lenses. Then also when you wear your contact lenses and you sleep and swim or use a hot tub while wearing it. And then also the cases are very important, because if you don't properly clean the cases of the contact lenses, it can form a biofilm of bacteria, and the Acanthoemba lives off bacteria, so basically giving it food. Then the male gender has also been associated with more cases, but they speculated it's due to more water activities or due to less hygienic, being less hygienic. Then warmer climates lead to a higher microbial load of these organisms in the environment, but also it's associated with more water activities. And then when they looked at age, it's usually younger patients younger than 26 years or above 55 years. So younger than 26 is again hygiene, water activities probably that's associated with these cases. And then above 55 years is more of the corneal degeneration that's a risk factor for Acanthoemba. So when we briefly look at the pathogenesis, so in a normal eye, our tears and by blinking and our immune system get rid of the Acanthoemba species. But when the epithelial layer of the cornea are traumatized, it expressed as manslated glycoproteins. And the Acanthoemba has a receptor for those glycoproteins called the mannose binding protein. So then obviously that's the first step of infection, is adherence. So it adheres, and then when it binds to this protein, it expresses MIP133, which is a mannose-induced protease, which then obviously leads to epithelial necrosis and further invasion of the trophozoites to the deeper layers. And once it's in the stroma, it also releases a range of proteases that can create the stroma and basically leads to necrosis. And then it also accumulates around the nerves, causing a radial neuritis, basically. And then they tend to not invade further into the eye. They just stay in the corneal layers, so you don't really see deeper infections with the trophozoites. So contact lenses obviously leads to minor mechanical trauma, and then your epithelial cells are traumatized. Also leads to hypoxia, reduces the metabolic rate and their resistance to infection. And then soft contact lenses is also a bigger risk factor than hard contact lenses, because it inhibits tears and the organisms can stick to them. So clinical manifestations is very non-specific. It's very similar to bacterial, fungal, hepatic keratitis, but your clinical manifestations it's usually unilateral, it's usually discomfort, foreign body sensation, tearing eye, usually visual acuity is, decreased visual acuity is in the later stages, and then usually these patients have pain that's disproportionate to the clinical sign. To the clinical signs, and then when we look at the signs, usually it's also misdiagnosed because it looks just like a bacterial or fungal keratitis. But one sign that's specific to Acanthoemba keratitis is this ring infiltrate, which is the top picture that you can see. But earlier stages, it's confined more to the epithelial cells, so you can have punctate epithelial erosions or pseudodendrites, ptosis and tearing, and later stages can include neovascularization, anterostromal infiltration, this ring infiltrate, hypopian, and more. And then extracorneal complications include scleritis, glaucoma, cataract formation, and then you can also have your extraocular muscles be affected. But all of this is more due to inflammation rather than the invasion of this trophozoites. So the diagnosis is very tricky, and the first step to diagnosis is usually to have a clinical suspicion. Like I mentioned, it's not part of our routine diagnostic to look for these organisms. And when you suspect it, it's usually better to have a range of different diagnostic methods to detect this organism to increase your sensitivity. So samples that will usually be sent to the lab to detect this organism include corneal scrapings, corneal biopsies, corneal smears, the contact lens itself, the contact lens solution, and then also irrigation of the contact lens case. And this review article also listed different diagnostic methods with their sensitivity and specificity, but obviously that is dependent on the reference method that they compared it to. So I'm not going to bore you and go into all of those, but just a brief overview of the diagnostic method. So this is obviously how they scrape the cornea with a specific spatula. So firstly, when they send us slides, they inoculate in the theater. Methods that it includes is a wet mount, but usually you need a phase contrast microscope, so not something that we have in our laboratory. And then you can do lactococcino blue stains or histopathological stains like Kim-style PAS, silver stains to detect these organisms. This is my pictures I took at NICD actually. So another method is culture, where you have a non-nutrient agar plate, you load it with a specific 80cc strain of E. coli, and then you inoculate your sample onto that. And the Acanthoemba eats the E. coli, and you can see the little tracks of the trophozoites in the E. coli lawn. Under the microscope, we will be able to visualize cysts or trophozoites. So at the top picture, it's cysts. So when all the E. coli is basically gone, or they ate it all, then they insist, and then you can see this. So this is a method to detect it. Then also in vivo confocal microscopy can be performed by the ophthalmologist himself in real time. They can make the diagnosis by just looking at the patient's cornea, and it has a very high resolution. You can see cellular and subcellular structures. So they also call this Acanthoemba the starry sky, so you can see lots of little cysts. And here you don't have to send a sample to the lab. You can make the diagnosis and you can start treatment immediately, which is quite nice because this is a long treatment. You don't want to get it wrong. Early diagnosis can lead to better visual acuity, but this is not available in South Africa, unfortunately. And then the last one is molecular methods such as PCR. So this is an example of conventional PCR, which is what NICD currently use for Acanthoemba. They are busy optimizing their a real-time assay to detect all the free genre of free living amoeba species. So treatment, not going to go into this, but treatment is also quite tricky, and it's back and forth and assessing the patient for improvement and adding agents or considering surgery. So this is from the University of Illinois at Chicago, and it's just a protocol, a management protocol that they published. But as I mentioned, good visual prognosis usually requires early diagnosis and the correct treatment. It's usually a prolonged course of weeks to months that you have to treat this patient. You want the agents to act on the trophozoites, cyst, and inflammation. And the tricky part is here is to kill the cyst. They're quite persistent. And then also in vitro or testing agents in vitro doesn't always correlate to in vivo efficacy. So it's a bit tricky to figure out what agents are effective. But basically the first line agents include this topical biguanide, so PHMG or fluoxetine at a concentration, or there's a range of concentrations that you can use based on your patient. They are cationic compounds that disrupted the negatively charged membrane. And then the other group that is commonly used is diamidines, also two options there. But to note that these agents are also toxic to the cornea itself. So you have to monitor your patient to prevent toxicity from the agents themselves. And there's quite an intensive treatment initially in the disease for the first 3 days. Every hour the patient must get the eye drops, and then later on only when the patient is awake every hour, and then you can titrate it to response. And then they've looked at additional agents including povidone iodine, multifacine, which is used in leishmaniasis, and then also antibiotics and antifungals that have been used to treat this Acanthoemba, but it's not clear if it's actually targeting the Acanthoemba's protein synthesis or DNA synthesis, or is the antibiotics just killing the food of the Acanthoemba itself. So corticosteroids are a bit controversial, but it should not be used in the initial phases of this disease, because obviously it's suppressing the immune system, but it also leads to the existence of these organisms. So then you create a lot of trophozoites and lead to a lot of damage, but you can use it later on in the disease. That's just a proposed therapeutic strategy. So you can add your corticosteroids on at a later stage, and you can have this period when you don't give the patient any antimicrobials to allow the cyst that's still there to exist, and then when it's trophozoites, you need them hard again with this topical agents. So for surgery, there is a role sometimes for it. So early on in the disease, you can abride the epithelial, and that then you obviously have samples sent to the lab, but also you decrease the microbial load, and agents can penetrate better. And then also other surgical interventions include deep anterior lamellar keratoplasty and then penetrating keratoplasty, which can be either therapeutic for corneal perforation, or it can be optical, just to improve the visual acuity after the patient has been cleared from infection. But usually that should not be done early on in disease. The patient have worse visual outcomes. Then the prognosis is usually not great. So 25% of patients suffer vision loss and require keratoplasty. And obviously it's dependent on how early you diagnose it and how aggressively you treat it. So prevention, just quickly, obviously, if you can prevent common risk factors, so that's contaminated water, especially when you wear contact lenses, and in corneal trauma. And then obviously your contact lens hygiene is very important. And then over the years, there have been a lot of contact lens solutions that have been recalled because they were associated with an outbreak of Acanthoemba species. And the top picture was one of these solutions that were recalled by the FDA in 2007 in America. And then, which is quite concerning, that you can buy contact lenses off Takealot or Shein without any healthcare professional telling you how to use it, how to clean it. And obviously patient education is quite important. Which brings me back to my patient. So she, before we had the culture and the PCR, she refused further treatment. She had some family issues, but they got her back a few days later to give her Brolin eye drops, which they got through the PTC committee. And then they followed her up at the clinic. They also had to get PHMB and fluoxetine from Durbanville Compound Pharmacy, which they bought through the petty cash of the department. But then because the patient was unable to manage with the ongoing pain and the therapy, she requested evisceration of the eye. So unfortunately in June, they did the procedure, and then at that stage the patient admitted that she actually wore cosmetic contact lenses. So it's still unclear if it was running into a haystack or if it's contact lenses that nobody obviously told her how to use this lenses. So just some learning points from this disease. This is the first pet that I ever dealt with, and I don't know if a lot of us have seen this, but it is a vision-threatening condition. It's very challenging to diagnose and treat, and obviously the quality of life, the patient's quality of life is highly compromised, and that keratitis should be managed by an ophthalmologist, not by GPs. Steroids should not be used without diagnosis, and then always to suspect this disease when the patient is not improving on antivirals and antibacterial agents. And then to also speak to your laboratory early, because you might think we're doing some tests, but so it's not always the case. And then also to improve patient education. Yeah, that's it.